Hello guys, sorry for the delay. Uh, Extremely sorry. Missed out one of the important components, so I was searching for it. Fine. So let's start without any undue delay. We are going to discuss in today's class the AIIMS recall, the last AIIMS which is conducted before the NEET. We're going to go with that recall. We'll go reverse, maybe 4-5 papers, so that we are done with whatever is required for us. Good evening, Wasabi. Fine. Okay. So as usual, we have a plus subscription. We have iconic subscription. We have a limited period offer going on if you require this. Please do attend the Medbind scholarship test. It's for you guys. Maybe you'll get a chance to win something worthwhile, whatever it is, your entire scholarship or something of that sort. But it's a good exam to attempt. I've seen the question personally, and we'll discuss them in the special class as well. Right, and you have few other things. 4-year subscription if you're a second-year student. There are a few new batches coming up this month. And use whatever code you have. If you don't have any code, you are more than welcome to use Pathocups. Fine. So we'll go with the first question. The first question here, what you're going to discuss is, am I audible? I hope I'm audible. If not, do let me know. Okay. The first question we are going to discuss is, which of the following is not a cross-linking fixative? See, this was a new question which was asked in the AIIMS. Right? Everyone went haywire after this question. And they started to read about more and more fixators. They wanted more and more lab procedures. They wanted more and more everything. So please don't do these things, because this is not a question for undergraduate. This is ideally a question for postgraduate. So every exam, not only in pathology, in every subject, there will be some outliers happening. 5 to 10% of the questions will not be able, you cannot attempt it. That's how the question is set. Fine. So read about that question. Don't go and read everything what's there in related to fixative, right? You need to know the basic stuff and maybe related to this question, right? So the first question comes here is, what is fixative? The ideology of fixative itself is wrong in multiple places for us. We are not sure what is exactly is a fixative and what's the purpose of a fixative. The main purpose of the fixative is not to fix the tissue to the slides, right? It's a very misconceived notion long back. I hope you don't have that notion anymore. The main purpose of fixative is to say, I'm taking a biopsy today from my body. This cell will die. Yes, obviously it will die. The cell is not going to be there forever. So, but I need the slide to diagnose maybe 5 years down the road, 10 years down the road, always, right? So the main purpose of the fixative is to preserve cell architecture. They're going to just freeze the cells. Okay, they're going to preserve the cell's architecture. They're just going to freeze the cell at one point, so there's no autolysis happening. They freeze and they're going to prevent autolysis. See, this is the main function of fixative, any fixative whatever we have. Okay. In addition to this, they also have one more function. That's not the most important cause, but they do that as well. They're going to prevent bacterial infection. Okay, because that's very common as well. Not only bacterial infection, any infection. Same problem when I'm going to take something from my body. Obviously, organisms will grow on that, especially fungus. Right? You keep a bread outside, fungus will grow. So when you keep a tissue outside, also fungus will grow. So this fixative is going to reduce it, especially fixatives of liquid. In moisture, there is more chance of growth. So these fixatives are few compounds which is going to prevent infectious organisms from growing them. Fine. So these are the main two purposes of any fixator. So now let's come to the fixator question per se. Which of the following is not a cross-linking fixator? Which means I need to know how many types of fixative are there and how fixators are classified. Right. So we'll go with the basic classification. When you take a fixative is classified based on two things. One, based on the chemical component, we classify them as a simple fixative and then compound fixative. This might be new for you guys. Do take it down, right? We classify them into simple fixative, compound fixative. Sometimes based on the physical property, like heat is also fixation. We already know one fixative, frozen section. Freezing is also a type of fixation, right? Frozen section, that was a physical. And there are few chemical fixators as well. Predominantly used ones are chemical fixators, fine? Physical fixators not much used, predominantly used chemical fixators. Then coming to this question, it is based on the type of chemical fixator. The type of fixation, how they're going to fix a tissue. There are a group of fixators called as coagulative fixators. What they do is, they just coagulate everything, fine? When I'm going to coagulate a protein, it's going to stay in the same state forever. Like you put an omelette, it's a coagulation of protein. Omelette is not going to change, but egg will change, right? Egg protein get precipitated, omelette is already done. So in that form of coagulation, we have a few fixators, right? Based on the type of fixation, we have few things called as in coagulation fixative. Okay, in coagulation fixative, we have almost all the alcohols, ethanol, methanol, acetone, acetic acid, picric acid, and all those things, right? So for us, main thing here is ethanol, methanol, and acetic acid. I'm not adding more and more things here. For the only reason we need to remember this. These two for sure you'll remember. Acetic acid also you'll remember, right? Or acetic acid or acetone. Because there is one condition which is used in the pathology lab where we use acetone-free methanol as a fixative. Where do we use acetone-free methanol as a fixative? Where? Perfect. We use it for peripheral smear examination, right? And acetone-free methanol is used as a fixative for peripheral smear, your Leishman stain. So you do remember that as well, right? So that is for your coagulant fixative. There are few fixative called as cross-linking fixators. So it's the way by which the fixator is going to act. They cross-linking between two chemical compounds, so they make them stabilize, so they're not going to let the cell degrade and they're going to preserve it, right? Aldehydes are cross-linking fixators. Formaldehyde, glutaraldehyde, acetaldehyde, everything are going to be your cross-linking fixators. Okay, your formaldehyde, like someone said, glutaraldehyde is useful for your electron microscopy. Perfect, it's an aldehyde, it's a fixative, cross-linking fixative. Your mercuric oxide. Okay, do you know any other fixative which is being useful for electron microscopy apart from your glutaraldehyde? I'm sure you do know few things as well. There's a fixative called as osmium tetroxide. Okay, that's also a fixative for electron microscopy. I don't use it anymore, not much. Glutaraldehyde is the standard fixative useful for all diagnostic as well as research purposes. The last one is chloral hydrate. Okay, again this is very least commonly used. Formaldehyde, glutaraldehyde is commonly used, fine. And there are few compound fixators. When I say something as compound, it has more than one action. Maybe it will act partly as coagulant fixative and partly as cross-linking fixative as well. We have something called as an alcohol formalin. As the name says, it has both alcohol from your coagulant part, formalin from your cross-linking part. So it has dual function, fine. Then I have combination of formaldehyde and glutaraldehyde. Again, it has two functions, right? So these are called as compound fixators. These are how fixatives have been classified. I'm sure you know this way of classification as well. Please stop here. Don't go and read what are the steps of fixation. Not required for you guys. It's for postgraduates. If you're going to do post-graduation, or maybe your new next pattern has introduced your internship in lab medicine. If that, when you're going to go to the lab, if they ask you, you might require to know. Otherwise, it's not required for us to know, right? Shasti, I'm not able to understand your question. What EG in compound means? Example is this. If you're asking that. Okay. Now when I come to this question, which of the following is not an? Yeah, alcohol formalin is in compound fixative, and your formaldehyde glutaraldehyde combination is in compound fixative, right? Which is not a cross-linking fixative. It is cross-linking fixative. It is cross-linking fixative. Osmium tetroxide is also cross-linking fixative. Alcohols are coagulant fixatives, right? So the answer is going to be methanol, right? Some of you said before itself, fine. Okay, that's the first question we are going to discuss today. Okay, the next one. This has become a trend of late, like to ask the correct sequence of adenoma carcinoma combination, right? We have few things with adenoma carcinoma combination. We will discuss about your colon today here. Maybe later on, like gastric also started to have an adenoma carcinoma combination. Your penile cancers have a sequence of adenoma carcinoma. Endometrium muffled a sequence of adenoma carcinoma. Right? All of them also we'll discuss when we come to the subject-wise classes. Fine. So when you look at this adenoma carcinoma sequence of a colon, this is actually a colonic adenoma carcinoma sequence, right? So we have two types of adenoma carcinoma sequence. Though your FAP related ones are much more popular, we should not leave the other one as well, right? So first we look at your traditional adenoma carcinoma sequence. When you look at a traditional adenoma carcinoma sequence, it is going to go from normal to your cancer state. When I have a traditional means, I'm going to talk about FAP. FAP is autosomal dominant or recessive? It is autosomal dominant, right? So I can have a germline mutation of APC or an acquired mutation. Anything can be there. When I have only APC, I'm going to have a normal mucosa, I have an APC hit, which can be inherited or which can be acquired. Right? I can have both. Once APC is there, I'm going to have many more other abnormalities. Like APC related beta catenin can also have a mutation. So you can have APC beta catenin mutation. Fine. After APC beta catenin mutation, I will have a RAS mutation. RAS is very important. That's like your proto-oncogene. It stimulates your abnormality. Fine. Next, you're going to have a KRAS mutation. KRAS mutation is where this normal will kind of become little bit abnormality will start. Right. You'll have an epithelial dysplasia. You'll have an epithelial abnormality here with RAS mutation. Though I may not have a tumor or a proliferative growth, there will be slight epithelial abnormality for sure. But for proliferative growth to happen, I need many more mutations. I need one of the worst mutations to happen here. Which is the worst mutation you know? You know one worst mutation, which is that? Which is your TP53, right? TP53 mutation is one of the worst thing. So to form a tumor, like a proliferative growth, okay, I need more mutations. One of the important one is TP53. Okay, we need a TP53 mutation, which is going to accelerate everything and is going to make the tumor a little bit bigger, right? Perfect. Along with TP53, I might have few more things, SMAD. Okay, I'll just ask you a question. There's SMAD2 as well as SMAD4. I'll take SMAD4 alone. Do you know any syndrome where SMAD4 is mutated? Any syndrome where SMAD4 is mutated? I'm sure you will know that. SMAD4 congenital loss you will have in your juvenile polypo syndrome. Perfect. Fine. Livelihood. TP53 is the gene. P53 is the protein. P stands for your protein with a molecular weight of 53 is P53, right? P63 means protein with a molecular weight of 63. That's all. Okay. So TP53 is a gene component of it, right? So I'm having a proliferative lesion. This proliferative lesion should invade, should spread, right? Invasion and spread is the next thing for a cancer. For invasion and spread, one of the most important thing which you require is the final hit of telomerase also should be gone, right? This for your traditional adenoma carcinoma sequence, APC beta catenin, KRAS, TP53 and telomerase. Okay. We also have one more syndrome. This is for your classical FAP syndrome. What is the other syndrome? Your HNPC syndrome, where your primary problem is in your mismatch repair genes, and MSH, MLH, all of them are mutated, right? So look at the adenoma carcinoma sequence of HNPCC as well, or your Lynn syndrome. Just a question. Let's see how many of you guys can answer that. What criteria is useful to suspect an HNPCC clinically? We have a criteria. We call this an Amsterdam criteria, right? Maybe it's a homework for you guys. Tomorrow or day after, I might ask you something about Amsterdam criteria whenever we want to learn about it. Fine, great. There is Amsterdam 1, Amsterdam 2. Please go through that. And maybe I'll introduce you to one more criteria called Bethesda criteria whenever time permits. Fine. So in Lynn syndrome, the primary problem for me here is the MLH, MSH, PMH2, all those mutations, which can be inherited or acquired. Both are possibility. If it is inherited, I'm going to call it syndrome. Fine. So you have a normal colonic mucosa. Like your APC abnormality, I'm going to have a mutation in MLH1, MSH2. Okay, this is more important. PMS2. Fine. Okay. Fine. These are the where it's going to get mutated. Can be again acquired or inherited based on the disease pathogenesis. Fine. After this, what's going to happen is you will have microsatellite instability happening. So what is a microsatellite is? Microsatellites are like normal tandem repeats in a chromosome. They are going to maintain lots of things. They are going to have a constant proliferation. They're going to have a constant division. So there's more chance of mutation in the microsatellite. So these guys ideally is going to protect the mutations in the microsatellite. Got it? I'll repeat it once more. I'm just simplifying it. It's a little bit more in detail. You have to learn about a microsatellite. We'll just simplify it for our ease. Fine. Just a second. Okay. So let's assume that this is a chromosome and this is a microsatellite. Okay, they are repeats. These microsatellites are the one which keeps on changing over the period of time. So when it changes over the period of time, rapidly dividing, rapidly proliferating, there's a chance of mutation here, right? So there's a chance of mutation here. Who is going to correct the mutation is your MSH MLH gene. So it will correct the mutation. So it's perfectly normal. If these are mutated, there's no one to correct that. So that's why we call them as there will be a microsatellite instability here. I will not know which microsatellite is getting unstable, but any number of microsatellite can become unstable because there's no one to correct the errors there. Fine. Okay. So that's about the microsatellite instability. So once microsatellite instability comes, again, I need few more things for it to grow and to become a cancer. With microsatellite instability, maybe I'll have something called as a serrated adenoma. This is a precursor in case of HNPCC. Sessile serrated polyp or a serrated adenoma, both means the same. Fine. After that, I need to acquire more mutations. Like your few mutations are much concentrated. Do remember that. Don't forget that BRAF. It's more concentrated for the only reason we have a drug against BRAF. What is the drug against BRAF? And we have one of the apoptotic gene BAX. Perfect. The drug against BRAF is vemurafenib, right? Darafinib or vemurafenib. Okay. TGF beta receptor 2 mutations. With the help of these mutations and maybe a little bit more of telomerase might also add in, it becomes a carcinoma. Okay. It's going to become a carcinoma. So here, for us to become a polyp in this condition of microsatellite instability, I don't want major mutations. Just the microsatellite instability alone can give rise to a polyp. Right? That's one important thing which you have to understand here. Fine. Okay. So this is the adenoma carcinoma sequence for Lynch syndrome. We have two adenoma carcinoma sequence. One was already asked. Maybe you'll go have a look at it. BRCA is not involved in adenoma carcinoma of colon. Not the correct sequence. MYH P53 APC not the correct sequence. So obviously the correct sequence is going to be APC, KRAS and then P53. Fine. Got it? Okay. We'll go to the next question. This is an important one. Again, this was a new thing which was asked. So when I have new things, we'll read about thyroid and a little bit about other things as well. Fine. Adequacy of thyroid FNACs. There are lots of things which require an adequacy in pathology lab. Right? It's not only thyroid FNAC. I do require adequacy for your bone marrow. I do require adequacy for breast FNAC. I require adequacy for everything. Right? So first we'll look at thyroid. Then maybe we'll go on to see other things as well. Fine. And adequacy for thyroid FNAC. And I'm going to talk about thyroid FNAC. There are two things. One is like to call it a colloid goiter or to call it an Hashimoto's thyroiditis. I require something like the standard criteria. But to call it a papillary carcinoma thyroid, it might not fit into the standard criteria. If I see even a single cell that's enough to diagnose, I'll still call it a papillary carcinoma thyroid, right? But an FNA smear, ideally, as per the standard guidelines, the adequacy is greater than 6 groups and each group should have greater than 10 follicular cells. Okay, each group should have greater than 10 follicular cells and all of them preferably on the same slide. That's also very important. I should have all of these in the same slide. What do I mean by that is, when you do an FNAC, you make multiple slides. You can't count like, okay, in this slide 2, in this slide 2, so totally 10. Same slide 10 follicles and more than 6 groups of follicles. In each of them, I'm going to have more than 10 cells groups, fine? On the other hand, exceptions. Exceptions are always required as well. Even a single intranuclear inclusion is diagnostic of papillary carcinoma thyroid. Do remember about it. Fine. That's enough for me to diagnose a papillary carcinoma thyroid, right? Let's assume that I'm doing an FNAC for thyroid, lots and lots of neutrophil, abscess. That doesn't require a thyroid follicular cell. It's an abscess cavity. I'm going to get neutrophils only, right? A thyroid abscess cavity. Fine. These, even if it is not fitting into my adequacy criteria, that's enough for me. Fine. I find one cell for papillary carcinoma thyroid, I'm happy with it. Full of colloid, I'm happy with it to call it a colloid goiter. I need somewhere few follicular cells, that's enough. I need not be strict on this. But on the other hand, if I have to give a report of follicular adenoma, Hashimoto's thyroiditis, I require at least 6 follicular groups. Fine. That's about your thyroid. So I have like that for your breast as well. We have like that for pap smear as well. Pap smear you have to know, because I think pap smear was somewhere being asked, right? What are the two types of pap smear which you know? We have two types of pap smear being done. One is your conventional pap smear, other one is your liquid based cytology, right? Perfect. One is conventional pap smear, other one is liquid based cytology. Okay, one is conventional, other one is liquid based cytology. So when you come to a conventional pap smear, the main difference is, I'm sure you must have seen pap smear being taken in your gynae ward. They put in a IS spatula, take it and make a smear and put in the alcohol container. That's conventional. If you look at LBC, they'll have something called as a brush. Same thing, instead of IS spatula, they put in a brush and they put in a box of liquid, they close the box and they send it along. They break it and send it along. They don't make a smear in the gynae OPD. For LBC, this is also called as LBC. The smear is made in the lab. Conventional pap smear, it's made at the bedside, right? Which means in a liquid-based preparation, it's been centrifuged. Centrifugation happens. Here, there's no centrifugation. Here, there's a direct smear. You have to understand the difference for sure. Now tell me, I have one thing which is a direct smearing technique. Other one, I'm having centrifugation. Cervix will have mucus, obviously, right? Along with your cervical epithelial cells, you'll have mucus as well. When you centrifuge, am I right in saying that the mucus will be gone? It will be gone, right? So my contaminant is gone. When my contaminant is gone, that's good for me, right? So it'll be easier for me to visualize. So maybe the number of cells required there is less. In a conventional pap smear, I should have minimum 8,000 to 12,000 cells. For an LBC, there should be a minimum of 5,000 cells. I'm talking about squamous epithelial cells only, right? Since the mucus, everything is gone, I might have less hindrance, so less number of cells is enough for me there, right? That's required. When do I call it something unsatisfactory? That also is required, right? We know satisfactory, so obviously we have to know the unsatisfactory item as well. If a cervical smear is completely full of inflammatory cells, I cannot comment on anything, or completely full of bacteria, right? Or blood, I cannot comment on anything. If a smear greater than 75% is obscured by blood, by bacteria, okay, or your inflammatory cells, greater than 75% of them are completely made of these, I cannot comment on that, right? You have to repeat the smear. If it's inflammation, wait for some time, let the inflammation subside, repeat the smear. If it's blood, see if there's any local injury or if the bleeding purging is the symptom, let it settle and then treat and then take a smear again, right? That's required, okay? Got it? This is for your pap smear. So we know for pap smear, we know for your thyroid as well. That's where we started, right? There are a few more places where we require adequacy. One is for your breast pathology, right? Breast pathology also I require adequacy, fine? Breast FNAC, though breast FNAC is almost obsolete, we are not going to recommend anyone. If any of your family members has any lesion in the breast, please go for a true cut biopsy, right? But if you do a breast FNAC, again the guidelines is Bethesda. Bethesda are the same guidelines for thyroid FNAC as well, right? I should have at least 6 clusters of ductal epithelial cell, and each cluster should be minimum 5 cells. Okay, 6 clusters of ductal epithelial cells, and each cluster should be minimum of 5 cells. So a minimum of 5 cells in your each cluster, right? That's for your breast FNAC. Okay, got it? Even for bone marrow biopsy and aspirate, we have adequacy. Okay, I'll just complete with bone marrow, then we'll go to the next one. A bone marrow biopsy, what you do is you're going to drill a piece of bone along with the bone marrow. It should be at least 8 to 10 millimeter. We say that 1 centimeter of bone marrow biopsy is kind of a good bone marrow biopsy, good yield. Okay, and in that 8 to 10 millimeter, I should have a minimum of 10 trabecular spaces. I'll tell what is trabecular space. Let's assume this is how I took the bone marrow biopsy, and let's assume this is your periosteum, the cartilage and everything, because that also will be part and parcel of it when you drill from outside, right? And okay, let's assume that my bone marrow starts from here. Your bony trabeculae, 3. Okay, so I'm going to call this as a single trabecular space. 1, 2, 3, 4. Okay, here I have 4 trabecular spaces. Minimum of 10 intertrabecular spaces is advisable, and if you take a 1 centimeter biopsy, good biopsy, you will definitely get that. Fine. Again, I have an exception. Exception is always there, right? If I find metastasis, tell me any cancer which can go to the bone marrow. I'm sure you'll know lots of cancer which can go to the bone marrow. When you find metastasis, I don't require 10 spaces. 1 space of mets is more than enough for me to call it metastasis. Or when I find granuloma, my first possibility is still going to be tuberculosis. One thing of granuloma is more than enough for me to suspect tuberculosis and anything, right? Yes, perfect. Prostate can go there. Many tumors can go there, right? Any metastatic foci, 1 foci is enough for me to call it, or granuloma, 1 foci is enough for me to call it. I don't want 1 centimeter biopsy. I don't want 10 intertrabecular spaces, right? That's for adequacy. What you have seen is you have seen adequacy for your thyroid, for your pap smear, for your breast FNAC, and bone marrow biopsy, right? Almost every biopsy has adequacy, but we'll stop with this for today's discussion. Fine. Next one. Which of the following is true regarding liquid biopsy? See, this was a new question again. This time this paper of AIIMS particularly had lots of new questions, right? Lots of new questions. When it comes, the student feels that it's very, very difficult for me. Keep in mind that if it is difficult for you, it is difficult for almost 95 to 98% of the people attending the exam. 2% of them, maybe they're super smart, they're outliers, they are not for the competition. Don't worry about it, fine? So we look at liquid biopsy. First, we'll understand what is a liquid biopsy and how do we do it and what are the utilities of liquid biopsy. Then maybe we'll come to the MCQ and see it, fine? So the question is, which of the following is true regarding a liquid biopsy, okay? So what is a liquid biopsy is? I'm sure that we must have learned about metastasis foci, right? We must have learned somewhere about metastatic foci. In the steps of metastasis, if you remember the steps of metastasis, we have one place that I'm going to have a tumor emboli, right? Tumor emboli formation. After that, it goes to different places. I'm just asking you a question. If I have a tumor emboli, and if I have a tumor emboli, am I right in saying that your tumor emboli is there in my body? Let's assume I'm having some cancer. Tumor emboli is there in my body. Blood. I can look at the blood tumor emboli and I can say, using some genetic analysis, I can say, okay, this person is probably having this particular cancer. Yes, that's possible. That's what we're going to do in liquid biopsy, right? So what we do in liquid biopsy is, there are 2 things. One is for cancer diagnosis. Other one is for prenatal testing. Prenatal testing is very popular than cancer diagnosis. Fine. So what I'm going to use in cancer diagnosis, the tumor emboli or the cancer cells in the blood circulation of a person with solid organ malignancy, right? We're going to look at the cancer cells in the blood, okay, for a particular thing, right? Cancer in the blood. I'm going to take it out. I'm going to analyze it, use some genetic markers, maybe IHC markers sometimes, and I'm going to give a diagnosis of not a blood cancer, of a solid organ malignancy. Okay. The other one, prenatal, like I said, it's a non-invasive prenatal testing. It's available in almost many places in the country, right? It's an upcoming thing. You have to know about NIPT because it has lots of implications. Like, what is the legal age for abortion? Fetal age. There's this kind of change in MTP Act. I forgot the change in MTP Act. But the legal age for abortion previously was 20 weeks, right? Right, so 20 weeks was previously the legal age of abortion. Maybe I think it was changed recently. I forgot about it. So when I'm going to say a patient is suspected Down syndrome, a patient is suspected case of Down syndrome. If a patient is a suspected case of Down syndrome, I'm going to confirm it by chorionic villus biopsy or an amniocentesis, right? Perfect, it's 24 weeks, great. So when I'm going to do a chorionic villus biopsy, when can I do it? The ideal timeline to do it, it's going to be around 14 to 16 weeks is where I'm going to do it, right? Both amniocentesis or chorionic villus biopsy, that is foolproof to say this patient has Down syndrome. Nuchal translucency is not foolproof. You need a foolproof evidence to call it Down syndrome. So which means previously, before this change in the MTP Act came, I can tell you with confidence at 14 to 16 weeks, and the legal age is 20 weeks. It's just a month. And when you do a chorionic villus biopsy, it's not available everywhere. That itself will take 2 weeks to get reported. So I'm left with 2 weeks for the parent to decide whether they have to go on with the baby or abort the baby, which is very, very difficult. So I'm just kind of giving them more pressure. That's why I wanted an early diagnosis. NIPT took care of that. NIPT can diagnose from 9th to 10th week. Okay. Second, what is one of the complications of chorionic villus biopsy or amniocentesis? Intrinsic complication of chorionic villus biopsy or amniocentesis is your abortion, right? That's one of the intrinsic complication of chorionic villus biopsy or amniocentesis. That's again a problem for me, right? So that is again a problem. Sorry, I'm not writing here. Chorionic villus biopsy, one of the complication is abortion. I cannot do anything. See, the doctor doesn't want to do it on purpose, but abortion is part and parcel of the disease. I can't do anything for that, right? That's one thing as well. So having all these problems, why should I go for a chorionic villus biopsy? This, I'm not going to touch the fetus. This is done on maternal blood. I'm not going to touch the fetus at all. I'm completely going to do on a maternal blood, right? So how do I do it on a maternal blood? We do remember something called as an RH incompatibility, right? So what we do in RH incompatibility is the antigen crosses the placenta and triggers an antibody response. If I'm right in saying if an antigen can cross placenta, am I also right in saying that DNA can also cross placenta? For sure, DNA will cross placenta, right? So I'm going to look at the cell-free fetal DNA here. Okay, I'm going to look at the cell-free fetal DNA here. Okay, that's what I'm going to look in the NIPT, right? So what we do in NIPT is I'm just going to take an early diagnosis. If we take 10 ml of maternal blood, the 10 ml of maternal blood, we filter out the cell-free DNA, cell-free fetal DNA, not the maternal DNA. When I get a cell-free maternal fetal DNA, obviously I'm okay with having a perfect diagnosis. I can easily diagnose Downs, not only Downs, Klinefelters or whatever it is, right? I can diagnose everything here, right? I can diagnose everything here, right? That's what we're going to see here. Okay, these are the two uses of a liquid biopsy, right? Can you hear me? Can you hear me? I think Victor KH, I think my sound is good. Okay, so these are two things here. Am I audible? Yes, fine. Okay, so this question is not about your NIPT. This question is totally about your liquid biopsy here. I think this question will have except. I missed it, fine. So when I have a liquid biopsy, okay, for cancer diagnosis, what I'm going to do is I'm going to study the tumor microenvironment, because when a cell breaks everything and goes outside, there'll be few information coming out of it from tumor microenvironment. I have to do a genetic analysis for which Sanger sequencing is done. Sanger sequencing is the way by which I'm going to do the genetic analysis. And the DNA here are tiny microvesicles. That's how they are there, right? There are going to be tiny microvesicles. That's how the DNA or the tumor cells, the tumor emboli will be there. So this is also correct. I cannot use urine. This is the wrong answer. I'm going to use blood. Blood is the way I'm going to do the test. And in the blood, the tumor burden will be analyzed, assessed, and we can give a diagnosis. So next question is, why do I need this? Why do I need this? Can't you take a biopsy of the breast parenchyma? If the patient has suspected breast cancer, you can. Can you take a biopsy of lung? Yes, you can. Pancreas? difficult. Brain, difficult. So this is especially suited for sites which are not accessible. Okay, I'm going to use it for sites which are not accessible, not every site. Fine. When I'm not able to take a brain biopsy, I'm going to use this. For them, they are good. Especially for a GBM diagnosis, it's very, very good. Right? They're developing, and liquid biopsy has been there for few soft tissue cancer diagnosis. GBM diagnosis has been approved, FDA approved, and I can use it as a diagnosis, less invasive or literally non-invasive procedure. Fine. That's a useful liquid biopsy. This is actually in Robbins. It came from Robbins only. It's not too hi-fi. It's there in Robbins. Almost every question which comes to the exam will be in Robbins. You're thorough with that, you're sorted. You need not go hi-fi at all. Thorough with that, you'll definitely get a rank between 1000. That will be more than enough for us, right? More than enough, at least for most of us. Okay. Last question for today. It's a simple question, straightforward one. Which of the following is true regarding celiac disease? Celiac disease, we know about it. It's a gluten sensitive enteropathy, right? Is CT scan required for diagnosis? No. CT scan is not required for diagnosis for celiac disease, right? How is celiac disease diagnosed? Clinical plus you have your serology, right? We're going to diagnose with clinical examination, plus clinical finding, history, plus serology. Serology is main thing for diagnosis. It's treated by complex carbohydrates and pasta. No. I should avoid everything. Bread, no, I should avoid, right? They do have wheat. The bro food should be avoided. That's how we treat. Most common cause of malabsorption in developing countries, no. What's a common cause of malabsorption in a country? Infection. I'm not going to think of celiac. Developed countries, maybe celiac. Again, it's not most common. It's a fairly common one in developed countries. Developing countries, definitely no, right? So these three are wrong statements. Yes, it will cause GL lymphoma. Obviously it will, right? Celiac is an autoimmune disorder. Whenever any autoimmune disorder comes, I'm going to have lots of cells, lymphocytes proliferating, destroying. In that due course, you can have a lymphoma. One of the important lymphomas, you have something called an enteropathic associated T cell lymphoma. This is a very, very aggressive lymphoma. You can have B cell lymphomas as well. An enteropathic associated T cell lymphoma is specific for celiac, right? Patients with celiac do have a very high chance of developing this cancer, which is difficult for us to treat. It's an aggressive neoplasm, right? Again, if it's untreated, it will result in it. If I'm going to stop the bro food, and if you're going to be very strict in your diet, the risk is substantially reduced, right? That's about celiac disease, okay? Fine. So these are a few questions which were there in the last AIIMS which is conducted before the NEET. In the couple of days, we'll be discussing almost all the AIIMS questions. Hopefully, if possible, JIBMA and PGMI questions are still somewhere. Previous year questions do make sense because at least somewhere related to the topic, if a new question comes, you should be able to write it. See, interleukin 15 also plays a major role in the pathogenesis, which triggers the T cells, and T cells will again secrete more cytokines, which will destroy my epithelium or the villus. Okay, great, fine. There should be an except aiming medico. I'm because these three statements are correct. If there's no except, I'm not sure how to go about it. There should have been either not true or except, because it studies tumor microenvironment, Sanger is used, and DNA is collected in microvesicles only. And dysautonomia. See, celiac can cause malabsorption. Celiac generally doesn't happen in duodenum. It can cause IDA maybe. Fine. Though it's not the primary presentation. Small intestine is affected in celiac. It can cause an IDA. Okay. Fine. Rather than saying celiac induced IDA, it could have been coincidental disease. Fine. Okay. Thank you for your time. See you tomorrow at 11. Hopefully tomorrow I'll be on time. Okay. Sorry for being late today. Thank you. Good night. Bye bye.